All right, guys, welcome back to Underground Science. In this video, we'll be talking about systemic sclerosis, also called scleroderma, okay? So let's go and get started. All right, let's get started with the pathogenesis. So remember, this is an autoimmune disease, all right? And it likely starts with endothelial injury, okay? So this can be, of course, triggered by certain environmental factors like viruses, right? Or an autoimmune reaction that can damage your endothelial cells, right? So, like viruses, autoantibodies, toxins, stress, right? Oxidative stress, for example. So, whatever the cause may be, we get endothelial injury, okay? Injury of our endothelial cells. If that happens, our endothelial cells can release certain things like endothelin, platelet-derived growth factor, even vascular endothelial growth factor, so even VEGF, right? Even adhesion molecules like cellular adhesion molecules, right? And what do those do? Remember, those help white blood cells go from your blood vessel and into your tissue, right? So adhesion molecules help white blood cells go to your tissues. Platelet-derived growth factor, right, does what? It can stimulate fibrosis. Vascular endothelial growth factor can stimulate angiogenesis, right, which is the formation of new blood vessels. And then we know endothelin leads to vasoconstriction, okay, which can lead to vasoconstriction, right? And so notice what's happening here is we get endothelial damage, which leads to certain things being released from our endothelial cells, and we have to focus on these molecules that are being released. Like endothelin causes vasoconstriction. Platelet-derived growth factor leads to fibrosis, right? So vasoconstriction will reduce blood flow to whatever organ this blood vessel is supplying, for example. And if you decrease blood flow to the organ, that can further contribute to fibrosis, right? And also, you're releasing a lot of platelet-derived growth factor, which can also contribute to fibrosis, right? Not only fibrosis and narrowing of the blood vessel itself, but also fibrosis of the organ tissue, right? Whatever organ this blood vessel is supplying, for example. All right. So not only do these damaged endothelial cells release these molecules, we also release damage-associated molecular patterns, right? Remember that we release DAMPs, right? Dying cells can release DAMPs. And remember, macrophages can engulf these DAMPs or these self-antigens, right? And present it to our self-reactive immune T cells that escape central tolerance. Okay, but we'll talk about that in a bit, right? So let's see what we have here. So remember, we said adhesion molecules will recruit more immune cells, right? So let's just remember the first step, endothelial injury. Due to whatever reason, maybe environmental factors like what, like silica, viruses, toxins, right? Oxidative stress, anything that will injure the endothelial cells can release certain things, right? Can lead to the release of certain molecules. Like what? Like endothelin, VEGF, CDGF, right? Platelet-derived growth factor, adhesion molecules. So so let's go through those now. So first step, endothelial injury, release of certain molecules from your endothelial cells. Adhesion molecules recruits more immune cells, like we already know, right? Like VCAMs and ICAMs, they recruit immune cells. Platelet-derived growth factor promotes fibrosis, not only in your blood vessels, right? But it can also, you can also get, we'll see later, you can get organ fibrosis too, okay? But PDGF promotes fibrosis. In this case, we're talking about, right? And when we say intimal fibrosis, we're talking about the tunica intima, right? And you can get fibrosis of the tunica intima and narrow your blood vessels, leading to ischemia downstream, okay? And we get endothelin release, which is also a vasoconstrictor, further contributing to ischemia and fibrosis. Okay, so that's the first thing we see. Let's see what happens next. Next, we get immune activation. Remember, our endothelial cells are getting damaged, so they're going to release self-antigens, right? Like what? Like damage-associated molecular patterns, which our antigen-presenting cells can recognize, or can engulf, I should say, and present. So remember, and there's also inflammation going on here too, right? So our macrophages will then, our antigen-presenting cells, due to the inflammation, can express B7. Remember that molecule? So remember, So let's just go through it, right? So we have damage occurring to our endothelial cells, like we mentioned in the previous slide. That will release certain things like damage-associated molecular patterns, right, or DAMPs, which are self-antigens. Our antigen-presenting cells can engulf that self-antigen and present it onto MHC2. It can go to a nearby lymph node and come in contact with a naive self-reactive CD4 T cell. Remember what needs to happen, right? We need our B7 and CD28 interaction and CD4 and MHC2 interaction, right? Once that happens, our T cells can get activated, right? And our antigen presenting cells can also release certain interleukins like interleukin 6 and interleukin 12. Interleukin 12 can make this naive CD4 self-reactive T cell differentiate into self-reactive Th1 cells, right? Your helper T cells, but the Th1 subtype. And your antigen presenting cells can release interleukin 6, which can make this naive self-reactive CD4 T cell differentiate into the Th17 subtype. Now remember, the Th1 subtype can release interferon gamma, right? Interferon gamma, which can attract and activate macrophages, right? Which can further contribute to inflammation because of macrophages can release cytokines, right? Which can further damage your blood vessel wall or your endothelium in general and underlying organ. And your Th17 subtype can release cytokines like interleukin 17 and attract neutrophils to the area of inflammation. And neutrophils, remember, can release proteases and reactive oxygen species and further damage your endothelium and underlying tissue. So both the Th17 and Th1 subtype, right? If we produce these T cells, they can lead to damage of the vascular wall, skin, and organs, leading to fibrosis and overall tissue damage. Okay, so that's a Th1 and Th17 subtype. What if, right? What if this antigen presenting cell released interleukin 4, let's say, right? Then that would stimulate these naive self-reactive CD4 T cells to differentiate into the Th2 subtype, right? And we know the Th2 subtype, and we know the Th2 subtype can release interleukins like interleukin 4, interleukin 5, right? And so on. And if you release interleukin 4, right, that can stimulate your self-reactive B cells to release autoantibodies, right? And we'll go over this in a minute. But your T cells in general, right, can also secrete things like transforming growth factor beta and interleukin 13, which are important to talk about because the whole problem with scleroderma is fibrosis, right? And transforming growth factor beta, guess what it does? Stimulates your fibroblasts, right? Which leads to what? Fibrosis. And interleukin 13 stimulates your fibroblasts, leads to fibrosis, right? So we're seeing a pattern here, right? All this inflammation leads to fibrosis. The cytokines released leads to fibrosis. Then in the previous slide, we said all the vasoconstriction that's occurring due to endothelial damage and endothelin release, right, leads to fibrosis. So if you're getting all this fibrosis, not this fibrosis occurring in your blood vessel walls, right, your tunica intima, and the underlying tissue. Okay, so that's the basic pathogenesis of scleroderma, right? It leads to fibrosis, overall fibrosis of your blood vessels and your underlying organs. All right, but how do these autoantibodies get produced? So your self-reactive B cells, remember, they can also internalize self-antigens, okay, due to all the endothelium, due to the destruction of the endothelium, release of self-antigens, right? Your B cells can take those self-antigens and present it, okay, on MHC2. Because remember, your B cells can present antigens, right? So this is your B cell, right? Your self-reactive B cell. It's presenting the self-antigen. Your self-reactive T cell binds to it, binds to the antigen via its TCR, right? T cell receptor. Then the CD4 binds to the MHC2. But we need one more interaction in order for the B cells to get activated, right? we need the CD40 on the B cells binding the CD40 ligand on the T cells. Once that happens, then that activates, right? Eventually activates your B cells, but once that happens first, then your T cells get activated, right? Your T cells now secrete interleukin-4 and 5, that which then causes your B cells, self-reactive, remember, to differentiate into plasma cells, who then release antibodies. What types of antibodies? Anti-centromere antibodies, anti-topoisomerase 1 antibodies, right? And anti-RNA polymerase 3 antibodies, right? Because, for example, if we take this antibody, right, if you destroy your cells, you can release self-antigens like we talked about. One of those antigens could be topoisomerase, right? It's a nuclear antigen or a nuclear enzyme. If your antigen presenting cells take that and present it to your T cells, then your T cells can get stimulated, right? As we saw like before. But if we're talking about B cells, right? If your B cells take in these topoisomerase antigens and present that, then you make antibodies against topoisomerase. That's why it's called anti-topoisomerase antibodies, right? It's also called anti-SCL70 antibodies too, okay? So because your self-reactive B cells get activated, and then that leads to differentiation into plasma cells, who then produce antibodies like anti-centromere antibodies, anti-topoisomerase 1 antibodies, and anti-RNA polymerase 3 antibodies, all right? So that's how autoantibody production works in this disease. Okay, so now we know we're getting a bunch of fibrosis and autoantibody production so far. All right, so let's go and see what happens or what happens next. So we already covered the main pathogenesis. Now we just have to cover the two types of scleroderma. The first type is called the limited type. Okay, in this, what you see is something called CREST syndrome. And CREST is actually a mnemonic to remember the findings, okay, of the limited type of scleroderma. So the C, right, is for calcinosis cutis, which you basically see calcium deposits in your skin, right, in your skin on your fingers, which is called calcinosis. Okay, so that's the first finding. Next finding, the R, right, stands for Raynaud phenomena, as we've seen in multiple autoimmune conditions like lupus, for example, right? So Raynaud phenomenon is when you have what you see, like let's say for your fingers, right? You would see um transition into certain colors of your fingers. So you would see a white, right? Due to lack of blood flow. So what can happen is if your blood vessels clamp down a lot, you can have at first you would see lack of blood flow. So you would see a white coloration of your fingers, for example, right? In this case, then due to the ischemia, you would see cyanosis for a little bit, which would turn blue, where you see a blue hue in your fingers. Then once blood flow gets restored, you'd see the red color, right? So it's this color change that you see due to blood flow changes from white to blue to red. Okay, white again due to low blood flow. Eventually, it leads to ischemia, so you see a blue color, and eventually blood flow gets restored, and you would see a red color. So it's just the events, the color change, right? Color change events basically that occur. Three main events that we should be familiar with: the white, the blue, the red color change. All right, that's Raynaud phenomenon. E stands for esophageal dysmotility. Here, what happens, you see atrophy of your lower esophageal sphincter, which can lead to trouble swallowing and gastroesophageal reflux disease. Okay, so if we draw your esophagus, right, what happens is, like, let's say you get fibrosis and narrowing, right? And if you get fibrosis, right, of the walls, for example, that can of course lead to overall trouble, right, in moving things down your esophagus. So you can imagine that can lead to trouble swallowing, right? And then if your lower esophageal sphincter, right, gets atrophied. So remember, let's say we draw our lower esophageal sphincter right here, right? And then you have your stomach like this, right? If your lower esophageal sphincter gets atrophied, right, means the size of the muscle gets smaller, right? Then that means that food from your stomach can go up into your esophagus, and that can lead to GERD, right? because all the acid in your stomach can reflux up into your esophagus, hence the name gastro, right from your stomach. Esophageal goes from your stomach to your esophagus. Reflux, because it's refluxing up, disease. Okay. And then we'll talk about GERD and Barrett's esophagus in the GI playlist. Okay. But that's a finding. Okay. So dysphagia and GERD. All right. And then the S stands for sclerodactyly. Sclerodactyly, all we have to know is due to the fibrosis of the dermis. Remember, fibrosis is the key thing that's happening in this disease. Okay, so your dermis gets fibrosed, right? Which can lead to tightening and thickening of the skin on your fingers. Okay, which can lead to a claw-like appearance. So imagine your fingers, right? The skin of your fingers can get really thick. So skin on your fingers right here, right, can get really thickened and tight due to all the fibrosis that's occurring in your dermis, okay, which can lead to sclerodactyly or a claw-like appearance. And the last but not least finding of the limited type of scleroderma is called telangiectasias, which are just basically dilated blood vessels on your skin. And you can find this on your hands and your face. Okay, so that's Crest syndrome, or the limited type of scleroderma. One last thing before we move on is in Crest syndrome, you can see a specific antibody, and that's the anti-centromere antibody. Okay, anti-centromere antibody. So actually, the C, right? You can remember that because anti-centromere, right? Centromere starts with a C, and calcinosis starts with a C. Okay, so you can remember that like that. So that's a limited type, but then there's also a more severe type called the diffuse type of systemic sclerosis, right? So systemic sclerosis has a limited type and a diffuse type. Now, the diffuse type involves your skin also, just like we saw in the limited type, but involves more areas, right? Like not only your fingers, so you can see sclerodactyly, again, which is the tightening and fibrosis of your dermis of your fingers, which can lead to a claw-like appearance, like we talked about. But you can also see fibrosis, right? Like, so basically thickening and tightening of your skin in other areas, like the skin on your face, chest, trunk, and arms. Okay. So that's that. And we talked about Raynaud's phenomenon already, and you can see that in the diffuse type. You can see calcinosis, right? And if the fibrosis gets really bad to the point where you're restricting blood flow to the skin tissue, you can see ulcerations in your fingers too, right? On your fingers. So that's the skin findings. But now we should talk about other findings too, like like what you would see. You would also see this, basically, is what I'm trying to say. Is you should also see this finding in the limited type, right? Remember esophageal dysmotility, right? Due to the atrophy of your lower esophageal sphincter, right? So that can lead to esophageal dysmotility, dysphagia, GERD, and so on, right? So we talk about that here. Your lower esophageal sphincter can fibrose and weaken, leading to GERD and dysphagia, right? So we saw that similarity in the limited type. So far, we have skin and GI, okay, in the diffuse type. In the skin, again, we talked about what? We talked about Raynaud's, calcinosis, right? Sclerodactyly, but you also see fibrosis and tightening on other skin areas like your face, trunk, arms, and chest. You can see ulcerations. Then in the GI system can be affected in the diffuse type, leading to the esophageal dysmotility, dysphagia, and GERD. Now, really important body system to be familiar with, right? A body system that can get affected in the diffuse type of scleroderma is your lungs. Okay, remember, fibrosis is what we're talking about, is the main thing we're talking about. So fibrosis can also occur of your lung tissue, right? Of your lung interstitium. Okay, and if your lung interstitium fibrosis, we can get restrictive lung disease, right? Which you talked about heavily in Sjogren's syndrome. But remember, the main thing to know here is you would see a decreased total lung capacity because you can't inhale as much as you would be able to because your lung walls are fibrosed. And then remember, in restrictive lung disease, you see the FEV1 FVC ratio greater than 80%, right? Because the FVC is lower than the FEV1. Okay, and so if you can't inhale properly, you can see shortness of breath and dry cough, right? Because you're not producing a bunch of mucus like you'd see in bronchitis. The problem is fibrosis, right, of your lung interstitium. So you'd see a dry cough, right? Minimal sputum production. Now, if you have lung fibrosis and you're not able to inflate your lungs properly, that means that you're not able to get proper amounts of oxygen into your blood vessels near your alveoli. If that happens, we know your blood vessels, your capillaries can constrict, right? So if we draw alveoli like this, and we'll draw another alveoli like this, for example, we'll draw another alveoli like this, right? Let's say you only have 3 alveoli in your lungs, right? Obviously, that's not the case, but let's say, and you have lung fibrosis, right? Fibrosis of your interstitium. So that's going to lead to you not being able to inhale properly. And also, if you have fibrosis of your interstitium, right, that's going to lead to a decreased DLCO value, right? Like we talked about in when we talked about restrictive lung disease and Sjogren syndrome, right? So that's going to lead to a decreased DLCO value, which means that this is basically measuring the how well your oxygen, right, in your lungs diffuses from your lungs to your blood vessels, right? So remember, we have capillaries flowing here, right? So we can have a decreased DLCO value due to fibrosis of your interstitium, right, and your alveolar walls. Okay, but that's a different point though. What we're mainly talking about is this, right? Why would you see pulmonary hypertension? Well, one reason can be this, right? If your lung walls are fibrosed, you get decreased oxygen delivery. And we know that in the lung vasculature, right, especially your pulmonary capillaries, if there's low oxygen, right, low diffusion of oxygen going into your blood, then you get constriction of your blood vessels. And if you constrict, because why does that happen, right? So let's say if we drew this individually, right? If we do this individually, right? Let's say we have capillary here for this alveoli, and then we have a capillary here for this alveoli, and then we have a capillary here for this alveoli, right? If this alveoli, right, is not getting enough oxygen, if this alveolus, right, is not getting enough oxygen, then this capillary, right, supplying this alveoli will constrict, okay? And if it constricts, why would it do that, right? Because why would you want to bring blood to this capillary if there's not much oxygen in the alveolus for it to diffuse, right? If you don't have much oxygen in this alveolus, then that means not much oxygen can go from your alveoli, right? From this alveolus specifically to your blood. So then you wouldn't want much blood coming here because that would waste that blood, right? That's coming. Because then if you have blood, if like let's say you have a lot of blood flow, right, coming here, but you don't have much oxygen here in this alveolus, then what's the point, right? There's not much oxygen. There's not much oxygen present to diffuse into the blood, into your red blood cells. So you would want blood flow to go other places, like to other alveoli that have plenty of oxygen in them, so that blood can be used. So that's why you constrict this blood vessel and you divert blood to other areas, to other alveoli that have proper amounts of oxygen, right? So that that oxygen can diffuse and go into your red blood cells. But if you have if you have diffuse fibrosis, right? If you have fibrosis of your lung interstitium, right? If like all of these alveoli fibrosed, if all of these alveoli are fibrosed, then you're going to be constricting all of these blood vessels, right? And if you the more blood vessels you constrict like this, that increases overall pressure, right, in your blood vessels. So that leads to increase in blood pressure, increase in the increased pressure, right, in your blood vessels, because vasoconstriction increases the pressure in your blood vessels. And remember, who's pumping blood to the right to your lungs, right? Who's pumping blood into these capillaries, right? That are supplying your alveoli for gas exchange. It's the right side of your heart, right? So the right side of your heart, your right ventricle in this case, we should say, right? Your right ventricle is pumping blood into the capillaries that supply your alveoli for the gas exchange. Now, if these capillaries are getting constricted, right, then that means that the right side of the heart, and remember, what do we say? Vasoconstriction will do what? Increase the pressure in these blood vessels. So the right ventricle, that means will have to pump against the high pressure system, right? So that can stress out the right ventricle, leading to right ventricular hypertrophy, and eventually could lead to right ventricular failure, right? So which is called cor pulmonale, which is what we said here. So let's go back to our lungs, right? Our lung findings. So because of the fibrosis, we get massive vasoconstriction of our capillaries, supplying our alveoli, which increases the pressure in our blood vessels in your capillaries, right? And who's pumping against that pressure? Your right ventricle. Your right ventricle is the one that's pumping blood to the lungs. If your right ventricle has to work harder, it can lead to right ventricular hypertrophy and eventually right ventricular failure, right? Which is called cor pulmonale. Okay. And pulmonary hypertension is when your capillaries all clamp down, and that can lead to an overall high pressure in your capillaries that supply your alveoli, which is called pulmonary hypertension. Okay. And again, your right ventricle will be the one to pump against that high pressure, right, in your lungs, which can lead to right ventricular failure, all right, which is cor pulmonale. Okay, so that's how the diffuse subtype can affect your lungs and your heart. An important finding to be familiar with is scleroderma renal crisis. Okay, it can affect your kidneys also. Remember, we're talking about fibrosis, right? What if your renal arterioles get fibrosed and narrowed, right? So remember, your renal arteriole feeds into your glomerulus, and then you have your efferent arteriole, right? If this renal arteriole, if this renal arteriole gets fibrosed and narrowed, that means less blood flow is going to your kidneys. And we know if your kidneys receive less blood flow, your JG cells get activated and release what? They release renin, right? Remember what renin does is it takes angiotensinogen released by your liver and converts it into, so we should actually draw it like this, right? It converts it into, let's erase this arrow, right? So and renin takes angiotensinogen and converts it into angiotensin 1, right? Angiotensin 1 goes to your lungs, interacts with your angiotensin converting enzyme, right? And gets converted into angiotensin 2. Angiotensin 2 causes widespread vasoconstriction, right? Which leads to increase in blood pressure or hypertension. And it it goes to your kidneys or your adrenal glands, remember, right? Specifically to your zona glomerulosa, right? Which is the first layer of your adrenal cortex. And that leads to the release of what? Aldosterone. Aldosterone, remember, goes to your distal convoluted tubule and increases reabsorption of sodium. And who follows sodium? Water, right? So therefore, you increase your blood volume, which then contributes to the high blood pressure. So if you're getting massive amounts of renin release because of the narrowing of your afferent arterioles, right, your renal arterioles, then massive amounts of renin means really high blood pressure. Therefore, this is called scleroderma renal crisis, right? Because it leads to acute malignant hypertension, right? Really high blood pressure. Why is it? Why did that happen? Due to the increase in the renin, angiotensin, aldosterone system, right? Which you just talked about. And it's really important to know that this this sclerodermal renal crisis is associated with the anti-RNA polymerase 3 antibodies. Okay, so that's important to keep in mind. Okay, so next body system the diffuse subtype can affect is your cardiovascular system, right? Remember what are we talking about? We're talking about fibrosis, right? We're hamming down on that concept. So your heart muscle, right? You can get fibrosis of your myocardium. So if you get myocardial fibrosis, right, you can't pump blood effectively out of your heart, which is not a good thing because that can lead to widespread ischemia, right, of your organs. And so that's if you get fibrosis of your heart muscle, this can also lead to restrictive, right? Remember restrictive cardiomyopathy, okay? Restrictive cardiomyopathy. And this can lead to diastolic heart failure, right? Remember that. We'll talk about this in our cardiac playlist. But if you have restrictive cardiomyopathy, your heart can't fill properly with blood, right? Because it's fibrosed. So if your heart wall is fibrosed, right? Let's say this is your right, let's draw it in a different color. Let's say this is your right atrium, right ventricle, left atrium, left ventricle. If your heart wall is all fibrosed, it can't fill with blood properly, right? It can't expand properly. That's why it's a diastolic heart failure, right? So if it can't expand properly, it can't fill with enough blood. And if it can't fill with enough blood, it can't pump enough blood. It can't pump as much blood as it would out and into the circulation, right? So, this can lead to a heart failure, but with preserved ejection fraction, because the ejection fraction is actually preserved, but it's still heart failure because it can't fill with enough blood. Okay, and if you can't fill with enough blood, then you can't pump enough blood out, right? Which can lead to ischemia of your organs. All right, so that's restrictive cardiomyopathy due to the fibrosis of your myocardium, but we can also see pericarditis and pericardial effusion due to the inflammation of your pericardium, which can lead to pericardial effusion, okay? Increased fluid in between your pericardial layers, right? Which can also affect how the heart functions, right? Because your pericardium surrounds your heart. So if you get pericardial effusion, right? So you can get things like you can hear things like friction rub, right, and so on. So that's how your heart's affected, right? And also remember, what does fibrosis do in your heart muscles, right? If you're or in your myocardium, if you see fibrosis, increased fibrosis puts you at a risk of arrhythmias, right? So you can see things like arrhythmias. And if you think about this, right, if your myocardium's fibrosed, you can't, your heart can't fill properly with blood, right? Because you have all this fibrosis surrounding it, which means that, like, let's say it can't fill with blood properly, then where is blood going to go? It's going to go back, right? So if, as we know, when blood comes from your lungs, it enters your left atrium, right? And then goes and your left ventricle fills up. But if your ventricles can't fill properly because of all this fibrosis, blood can back up into your atrium, right? Into your atria. And if we take the left atria, for example, right, it can back up from your left ventricle to your left atria, and then that can make your atria bigger. And we know atrial dilation puts you at a risk for arrhythmias. Okay, so atrial dilation, right, also puts you at an increased risk for arrhythmias, like reentrant circuits, for example, right, which can lead to arrhythmias or irregular heart rhythms, right? Like what? Like AFib, for example. Okay, so that's important to know. And then that's basically it, right? So that's the main, um, those are the main findings for the diffuse subtype of systemic sclerosis. All right. So again, just to review, right? Or just to go over the autoantibodies that we see in the diffuse subtype is going to be anti-topoisomerase 1, which is, remember we said that was also anti-SCL70 and anti-RNA polymerase 3, okay, antibodies. So remember, anti-RNA polymerase 3 is associated with scleroderma renal crisis, and anti-topoisomerase 1 or anti-SCL70 it predicts a higher risk of interstitial lung disease, right? So associated with interstitial lung disease. All right, so that's basically scleroderma. I hope this video wasn't too confusing. I hope you guys learned a little bit. Thank you guys for watching and see you guys in my future videos.